Unlike your muscles, which, can store up energy for a rainy day, your brain has virtually no biological savings account.
Right.
There are no fat stores up there.
Right. Zero.
Yeah, minimal glycogen. The human brain is just this hyper-demanding engine that is completely 100% dependent on a continuous second-by-second flow of blood.
It needs that constant delivery of oxygen and glucose or else things go wrong fast.
Exactly. If you cut off that blood supply to a region of brain tissue, the neurons in that territory begin failing in seconds, and, they begin dying in minutes.
It's just a terrifyingly fragile system when you actually look at the raw anatomy. And that single biological constraint, that absolute lack of backup fuel, is the entire reason why the medical emergency we're discussing today is organized around one singular metric.
Speed.
Speed, yeah. The brain is the most complex structure in the known universe, but it is incredibly unforgiving when it comes to its supply chain.
Okay, let's unpack this. Welcome to today's deep dive, where we are exploring the clinical reality of a stroke. If you're listening to this, our mission today is to completely deconstruct the famous FAST acronym, the one you've probably seen on billboards or in hospital waiting rooms.
Right, it's everywhere now.
It is. And we're going to dig into the mechanics of why the two main types of stroke are absolute biological opposites. We'll also explore how modern medicine is fighting a literal race against the clock here.
Yeah, and by the end of this deep dive, you're going to possess the kind of actionable structural knowledge that could literally dictate whether a stranger, a coworker, or, a loved one survives an emergency.
Which is a heavy promise, but the stakes really are that high.
They really are. But before we get into how to intervene in a stroke, we kind of have to grapple with what a stroke actually is.
Which sounds simple, but it's not.
No, not at all. The medical consensus of what constitutes a stroke has completely changed over the years. It's this moving target that basically tracks our technological ability to look inside the skull.
Right, because historically, medicine didn't even recognize this as a vascular issue. If you look at the origin of the word stroke, it's this descriptive holdover from ancient times.
Yeah, going way back.
Like Hippocrates, around 400 BCE, he used the Greek term apoplexia. The idea was that a person was suddenly struck down, almost as if by a physical blow from the gods.
And that concept persisted in Western medicine as apoplexy for centuries. You'd read these historical accounts of someone suffering a fit of apoplexy, and the treatment was basically to just, put a cold cloth on their head and hope for the best.
Just wait it out.
Exactly. For most of human history, a stroke wasn't something you actively treated. It was a fate you quietly managed. It wasn't until pathologists in the 1800s and 1900s started doing detailed autopsies that physicians realized they were looking at a plumbing problem.
An issue with the blood vessels.
Right. And by the 1990s, public health organizations like the American Stroke Association made a deliberate push to rebrand the condition as a brain attack.
Oh, to borrow the urgency of a heart attack.
Yes. They wanted to signal to the public that, hey, this is an active emergency requiring immediate hospital transport.
But the clinical definition, like the actual rules doctors used in the emergency room to diagnose it, was still lagging way behind that whole public relations campaign.
Oh, massively.
Yeah, because for decades, the working definition was codified by the World Health Organization back in 1970. And it was entirely time-based.
Right, the 24-hour rule.
Right. The WHO defined a stroke as rapidly developing signs of a disturbance in cerebral function lasting more than 24 hours, meaning the entire diagnosis hung on a ticking clock. If your slurred speech and facial droop lasted 24 hours and 1 minute, boom, you were stamped with a stroke diagnosis.
And the flip side of that rule was incredibly dangerous. Because if your symptoms lasted, say, 23 hours and 59 minutes and then vanished, the WHO said you technically had a TIA.
A transient ischemic attack.
Exactly. Or, in popular culture, we call this a mini-stroke. Under that old framework, patients whose symptoms cleared up before that 24-hour mark were essentially told they had dodged a bullet.
They were just sent home.
Yeah, sent home with this comforting illusion that their brain had experienced a harmless power outage, with no lasting damage.
It's like telling someone they survived a house fire just because the flames went out, completely ignoring the fact that the living room is now charcoal.
That's a perfect way to put it.
But that 24-hour rule didn't survive the invention of modern MRI machines. Because once clinicians could actually see inside the living brain in high resolution, the entire illusion of the harmless mini-stroke completely fell apart.
Yeah, the game changer was a specific type of MRI scan called diffusion-weighted imaging. And without getting bogged down in the physics of it all, this scan measures the random motion of water molecules in tissue.
Okay.
So when brain cells are starved of blood, their internal pumps fail and they swell up. Water gets trapped inside these dying cells. The MRI detects that trapped water and lights up the screen with this bright white spot.
Oh, wow.
Right, so clinicians started putting these TIA patients, the ones whose symptoms fully resolved within an hour, into these MRI machines, and the scans lit up.
They found visible dead tissue.
Exactly. Their brain had infarcted, which is the medical term for tissue death, due to inadequate blood supply.
So they just got lucky with symptom recovery.
Yeah, maybe their adjacent blood vessels naturally reopened the territory just enough to restore function. Like you said, the fire had charred the wood, they just couldn't see the smoke anymore.
So the damage was permanent.
Yes, which is why in 2013, the AHA and ASA formally overhauled the definition. It's now tissue-based. Regardless of how long symptoms last, I mean, even if it's just 20 minutes, if an MRI shows cell death attributable to a vascular cause, it is officially a stroke.
So today, a TIA is absolutely no longer considered a reassuring near miss.
No, not at all. It is a documented high-risk warning. In fact, roughly 1 in 5 TIA patients will have a full massive stroke within 90 days.
Wait, really? 1 in 5?
Yep, with the highest risk concentrated right in the first 48 hours.
That's wild. Okay, so understanding that a stroke is fundamentally about dying brain tissue leads us to what is basically the most critical crossroads in all of emergency medicine.
The ultimate fork in the road.
Exactly.
Yeah.
Because there are two fundamentally different ways that blood supply can be disrupted, and they are mechanistic opposites.
Right. So the vast majority, roughly 87% of all strokes, are ischemic strokes. Ischemia simply means restricted blood flow.
Got it.
This happens when a blood vessel supplying the brain is blocked. The vessel wall itself is perfectly intact, but, blood just cannot get through.
And usually this is caused by a clot, right?
Yeah, exactly.
It could form locally in the brain's arteries, or it could be an embolus, which is a clot that forms somewhere else in the body, breaks loose, and travels up the highway of your arteries until it wedges into a tiny vessel in the brain.
And a classic driver of this is an irregular heartbeat called atrial fibrillation, or AFib.
Right. In AFib, the upper chambers of your heart don't squeeze properly. They just sort of quiver.
Yeah, and because the blood isn't being forcefully pumped, it pools in the crevices of the heart. Pooled blood gets sticky and coagulates into this jelly-like clot. Then the heart finally gives a good pump, and that clot shoots straight up the carotid artery into the brain.
Which accounts for the 87% blockages. But the remaining 13% are hemorrhagic strokes.
Right.
And hemorrhage means bleeding. These occur when a blood vessel literally bursts and bleeds into or around the delicate brain tissue.
And chronic high blood pressure is a massive culprit here. Over years and years, high blood pressure acts like a water hammer on the pipes of your brain, weakening the vessel walls until they finally rupture.
Or it could be a ruptured aneurysm, right?
Yeah.
Like a pre-existing balloon-like bulge in an artery that suddenly pops.
Exactly, filling the space around the brain with toxic pressurized blood.
So here is the rule that dictates everything that happens in a hospital. You have a clot versus a bleed, ischemic versus hemorrhagic. The frontline drug for treating an ischemic stroke to the blockage is a powerful clot-dissolving agent. Drugs like TPA, or newer ones like tenecteplase.
Right.
But if you administer a systemic clot-dissolving drug to someone who is actively bleeding into their brain cavity...
It will kill them. Yes. The drug will dissolve whatever natural clotting their body is trying to do to patch the ruptured artery, and the bleeding will accelerate catastrophically. The danger here is that a hemorrhagic stroke and an ischemic stroke look virtually identical from the outside.
A drooping face, slurred speech, sudden paralysis on one side of the body.
Exactly. You cannot reliably distinguish a clot from a bleed just by examining the patient at the bedside.
Which creates a terrifying diagnostic catch-22. To save the ischemic patient, you need to give a clot-busting drug immediately. But to give that drug, you have to be absolutely certain they aren't bleeding.
And this is why a non-contrast CT scan of the head is the absolute mandatory checkpoint for every single stroke patient.
Okay, that makes sense.
Yeah, the CT scan is extremely good at detecting fresh blood, which shows up bright white on the scan. You're scanning them specifically to rule out a bleed before you clear the use of the drug.
Here's where it gets really interesting, though. If the outward symptoms are identical, how did emergency rooms handle this before CT scanners existed? Was it just a terrifying coin toss?
Well, if we look back to the era before CT scanners and clot-busting drugs, there wasn't a diagnostic catch-22 because there wasn't a medical treatment to offer.
Oh,
Yeah.
right.
You simply provided supportive care, you made sure the patient was breathing, you managed their fluids, and you basically waited days or weeks to see what permanent brain damage they were left with.
Wow, that's grim.
It was. The modern stroke protocol, where a team races a patient from the ambulance bay straight to a scanner to safely administer a biological agent, is a pure marvel of the late 20th century.
But because that CT scan is a mandatory hurdle, time becomes the ultimate enemy. The tissue is actively suffocating while the patient is being transported, while they're being scanned, and while the images are being read. Every single delayed minute has a quantifiable biological cost.
Yeah, and the paradigm shift for treating this occurred in 1995 with a landmark trial published by the National Institute of Neurological Disorders and Stroke.
In the New England Journal of Medicine, right?
That's the one. This trial proved that if you gave intravenous TPA within 3 hours of the onset of an ischemic stroke, patients were significantly more likely to recover with minimal or no disability.
Let's break down how TPA actually works, because it's fascinating. It stands for Tissue Plasminogen Activator.
Right.
When a blood clot forms, it's held together by this tough, stringy protein mesh called fibrin. TPA activates an enzyme in your blood called plasmin, which essentially acts like biochemical scissors.
Perfect analogy.
It swims up to the clot and snips the fibrin mesh to pieces, dissolving the roadblock and restoring blood flow. But it only works if the brain tissue downstream is still salvageable.
Right, and medical professionals refer to this salvageable tissue as the ischemic penumbra.
The penumbra.
Yeah. When a vessel blocks, there's a core area of brain tissue that dies almost immediately. But surrounding that dead core is the penumbra, a zone of tissue that is functionally impaired, starving for oxygen but still barely clinging to life thanks to tiny adjacent blood vessels trying to share their supply.
And that penumbra is exactly what time-critical treatment is fighting to rescue before the cell death spreads outward.
Exactly.
To make that abstract idea visceral, let's look at the numbers. In 2006, a neurologist named Jeffrey Saver published an analysis of what physically happens during a typical large vessel ischemic stroke. He calculated that the average patient loses about 1.9 million neurons every single minute that treatment is delayed.
And he also calculated the loss of roughly 14 billion synapses, the connections between those neurons per minute.
1.9 million neurons a minute. I mean, it turns hurry up from a vague feeling into something visceral. It's like an hourglass. But every single grain of falling sand is a million brain cells.
An entire encyclopedia of memories, motor skills, or language processing is wiped out every 60 seconds. Saver concluded that each untreated minute of a stroke ages the brain by roughly 3 weeks.
3 weeks.
Very minute.
Yep. This is why you'll hear hospitals bragging about their door-to-needle time. How fast can they get a patient through the automatic sliding doors, into the CT scanner, and start pushing the TPA into their findee? Right, hospital efficiency is critical. But doctors quickly realized they had a massive bottleneck occurring long before the patient ever reached the sliding doors.
Oh, absolutely.
You can optimize a triage team to the second, but it means nothing if millions of neurons are dying while the patient is sitting on their couch, hoping their numb arm is just a pinched nerve, debating whether to call an ambulance.
And that's exactly why the medical system needed a way for untrained bystanders to recognize a stroke instantly.
Because in a hospital setting, doctors use a highly complex assessment called the NIH Stroke Scale, or NIHSS. It's a 15-item exam.
Right. You check their gaze, their visual fields, their reaction to pinpricks, their ability to name objects.
It's a brilliant tool for quantifying exactly how bad a stroke is.
Yeah.
But you absolutely cannot ask a panicked spouse to perform a 15-point neurological exam in their living room.
No, you need simplicity.
Yeah.
So in 1997, a researcher named Arthur Kothari and his team at the University of Cincinnati took that complex hospital exam and ruthlessly stripped it down. They created the Cincinnati Pre-Hospital Stroke Scale, focusing on just 3 overt physical checks: facial droop, arm drift, and abnormal speech.
Face, arm, speech.
Exactly. It was engineered so paramedics could perform it in under a minute on someone's front lawn, accurately flag a likely stroke, and radio ahead to trigger a stroke alert at the receiving hospital.
Which was a massive leap forward for paramedics. But in 2003, a team in the UK led by Gary Harbison realized the general public needed an even simpler behavioral trigger.
Right, because strokes were finally treatable, but only if people mobilized instantly.
So Harbison's team took those 3 paramedic checks, face, arm, speech, and added a crucial fourth element, time. And the FAST acronym was born.
Face dripping, arm weakness, speech difficulty, time to call emergency services.
It's a masterpiece of public health engineering. It compressed a highly clinical diagnostic question into an actionable behavioral instruction that could be memorized from a single 30-second television commercial.
It really empowered the everyday bystander. But, as with any simplification in medicine, when you condense neurology into a catchy acronym, you inevitably create blind spots.
Yeah, that makes sense.
SSS is a screening tool, not a comprehensive diagnosis. And it has a heavily documented anatomical flaw. It focuses almost exclusively on the territory served by the anterior or carotid circulation of the brain.
The front part of the brain that controls motor function and speech.
Right. It completely misses strokes happening in the back of the brain.
The posterior circulation strokes. These affect the cerebellum, or the brainstem, which are supplied by the vertebrobasilar artery system in the back of your neck.
And the cerebellum controls your balance and coordination, while the brainstem controls your vital functions and eye movements.
So a famous high-profile example of a posterior stroke occurred in 2001 with the actress Sharon Stone. She suffered a subarachnoid hemorrhage caused by a vertebral artery dissection.
Yeah, and a dissection is when the inner lining of an artery tears. Blood forces its way into the tear, separating the layers of the artery wall and creating a bulge that can either block blood flow or rupture entirely.
And when Sharon Stone experienced this, she didn't have a facial droop.
No.
Her arms weren't weak. She wasn't slurring her speech. Posterior circulation events present with sudden severe headache, extreme vertigo, loss of balance, double vision, or nausea.
None of which are in the FAST acronym.
Right. A well-meaning bystander relying entirely on a FAST billboard would likely assume the person just had severe food poisoning or a migraine.
Exactly. And because younger patients with these posterior strokes are often tragically misdiagnosed at triage with inner ear issues or complex migraines, many modern healthcare systems have adapted the acronym.
To be FAST.
Yes. They added B for balance, sudden loss of coordination, and E for eyes, sudden blurred or double vision.
Expanding the net to be FAST is a vital correction. It catches those cerebellar strokes. The trade-off, of course, is that casting a wider net catches a lot of dolphins alongside the tuna.
It does, yeah. Emergency departments see a high rate of stroke mimics. Anywhere from 1/5 to 1/3 of code stroke alarms triggered in ERs turn out to be something else entirely.
Like what?
Well, extreme hypoglycemia, low blood sugar can bizarrely mimic a stroke, causing one-sided weakness. Certain severe migraines with auras can cause temporary paralysis.
But emergency physicians broadly accept these false alarms, right?
Oh, absolutely. Because BE-FAST is meant to trigger urgent transport and get the patient into a CT scanner, not to finalize a diagnosis on the sidewalk.
Speaking of emergency physicians, we have to acknowledge that medicine is rarely as clean as a textbook.
Very true.
The adoption of TPA, that miracle clot-busting drug from the 1995 trial, was actually highly contested.
Oh, yeah. There was, and in some circles still is, a genuine controversy informally called the TPA wars within emergency medicine.
I love looking into the debates because it shows how evidence-based medicine is actively contested. Skeptics, led by prominent emergency physicians like Jerome Hoffman, argued for years that the original 1995 trial overstated the benefits while minimizing a very grim reality.
The bleeding risk.
Yes.
When you inject a systemic drug that destroys blood clots, you run the very real risk of causing a spontaneous hemorrhage in the brain. In that 1995 trial, the rate of symptomatic brain hemorrhage was about 6.4% in the treated group compared to just 0.6% in the placebo group.
Wow, that's a big jump.
It is. For emergency doctors, looking at a patient who came in with a blocked vessel and accidentally giving them a fatal brain bleed is the ultimate nightmare.
Yeah, critics looked at the number needed to treat versus the number needed to harm, and felt the statistical foundations were a little shaky. It's a vital reminder that a pivotal trial can become the global treatment standard, while a meaningful minority of practicing physicians remain deeply skeptical of its real-world application.
Fortunately, though, technology didn't stop with TPA.
Yeah.
For years, the treatment window for an ischemic stroke was hard-capped at around 3 to 4.5 hours. After that, doctors assumed the penumbra was entirely dead, the window was closed, and giving TPA would only cause bleeding with no benefit.
But in 2018, that decades-old assumption was spectacularly overturned by two major trials, known as DAWN and Diffuse 3.
And they weren't testing a new drug.
Right. They were testing a mechanical intervention called an endovascular thrombectomy. Thrombus means clot, and cractomy means removal.
Exactly. Instead of flooding the whole body with a clot-dissolving chemical, a neurointerventionalist threads a long, thin catheter into an artery in the patient's groin or wrist, navigating it all the way up through the chest, into the neck, and directly into the blocked vessel in the brain.
Which is incredible.
It really is. They deploy a tiny wire cage called a stent retriever that physically meshes with the clot, captures it, and pulls it entirely out of the body.
It is breathtaking to watch on imaging. What Dawn and Defuse 3 found was that for select patients with a large vessel blockage, this mechanical removal could save brain tissue up to 24 hours after symptoms started.
Up to 24 hours.
Wait, but we just established that the average patient loses 1.9 million neurons a minute. How on earth can brain tissue survive for an entire day without its primary blood supply?
It comes down to this brilliant piece of evolutionary anatomy called the circle of Willis.
Okay.
It's a literal ring of connected arteries at the base of your brain. Think of it like a traffic roundabout. Blood comes up through your neck arteries and enters the roundabout before branching off to different hemispheres of the brain.
Oh, I see.
Yeah, if one of the major exits is completely blocked by a clot, the blood can actually take the long way around the circle, reversing flow through smaller collateral vessels to reach the starving tissue from the back end.
It's the brain's natural backup plumbing system.
Precisely. And every individual's collateral blood supply is genetically and structurally a little different. Some people tolerate a blocked vessel far better than others because their circle of Willis efficiently reroutes the pressure, keeping that ischemic penumbra alive for hours.
So the old mantra, time is brain, is absolutely true. But the speed of the timer varies wildly person by person.
Exactly why advanced imaging is so critical now. We no longer just look at the clock, We look at the tissue to see if the patient's collateral vessels have bought us enough time to go in and pull the clot out.
So if you're listening to this, what is the ultimate takeaway? First, we have to dispel the dangerous myth that a stroke is purely an elderly disease.
Absolutely.
While risk undoubtedly rises with age, stroke incidence in adults aged 18 to 44 is actually rising. This can happen to young people.
Second, understand that the danger doesn't vanish the moment the clot is removed or the bleeding stops. Brain swelling from a large ischemic stroke often peaks 2 to 5 days after the initial event, which can be fatal.
And hemorrhagic strokes carry severe ongoing risks of rebleeding and artery spasms for days or weeks.
Right. The acute danger period in the ICU is much longer than the initial attack.
But the absolute most important takeaway is why you should care about the BE-FAST acronym. Knowing to check for balance, eyes, face, arm, and speech, and noting the exact time the person was last seen normal is one of the very few pieces of layperson medical knowledge that can literally dictate whether a human being walks out of a hospital or spends the rest of their life permanently disabled.
You, the bystander, are the first vital link in the chain of survival. If you see the signs, even if it's just sudden vertigo and double vision, you do not wait to see if it passes.
Ever.
You do not let them sleep it off. You call emergency services immediately, let the paramedics trigger the alert, and let the CT scanner sort out the clot from the bleed.
I want to leave you with one final forward-looking thought. We just explored the incredible mechanics of the Circle of Willis, that natural traffic roundabout that can keep brain tissue alive for up to 24 hours in some lucky individuals.
Yeah.
If our own collateral circulation is the key to extending that treatment window, could the future of stroke medicine fundamentally shift?
How do you mean?
Could we eventually focus less on just racing to dissolve the clots and more on finding ways to instantly dilate and boost the brain's natural backup plumbing the exact moment a stroke happens, buying every single patient the time they need?
Now that is a truly fascinating frontier.
Something to mull over. Until next time, keep diving deep.